Pitfalls in POCUS. I really have no disclosures related to this talk. I will say that I have an IUH values grant for POCUS education at Riley Hospital where I work. And so I'm the local POCUS champions, if you will. Limitations, most of the images are acquired by myself, so the quality may not always be as amazing as you would see published somewhere. But they are acquired during my clinical practice. So the patients are what they are, and the windows are sometimes good, sometimes not so good. So maybe that's also a benefit. I did borrow a few from friends on the internet. And then there are some examples where I did not find POCUS examples, but I used radiology and echocardiography clips as example for the concepts that I will be discussing. And then probably most importantly, I'm just scratching the surface with this talk. This is a very complex topic and one could take it in many directions. And so I'm just more like wanting to pique people's interest about this. And with that, let's just get started. So why talk about POCUS pitfalls? You know, a lot of POCUS enthusiasts, including myself, frequently think or have thought, you know, POCUS does not have to be perfect to be useful. You know, you're just good enough, you get what you need. If you don't know what you're seeing or you can't get anything, you ask for help. So it is good as it is. And sometimes this is true. You know, you'll get a picture like this, where essentially the effusion tells you, just drain me, please. It's not complicated and you can just get it right away. So then why talk about this? Well, it turns out that POCUS has had the unfortunate fame of being named top 2 tech hazard between surgical staplers and surgical robots in the ECRI 2020 report. ECRI, I actually learned not too long ago. It is a emergency care research institute. It is a independent nonprofit that aims to improve the safety, quality, and cost effectiveness of all care. So they do actually test lots of types of equipment. And after looking at POCUS use over many types of healthcare settings, they came to this conclusion that while point-of-care ultrasound scanners are changing the practice in many specialties, however, safety measures have struggled to keep up. So they point out that POCUS can be dangerous. Okay, in what way could that be? So the potential for harm can come from misdiagnosis, for example, confusing an air-filled bowel for a gallstone, inappropriate use of modality, for example, using POCUS for a clinical application for which other image application may be better, over-reliance of POCUS when a more comprehensive exam by imaging specialist is indicated. Probably the most common example would be to over-conclude from a POCUS cardiac exam when in fact an echocardiography would be more indicated. And then POCUS not being used when warranted. It turns out that while there's all these problems with POCUS, ECRI says also not using POCUS when warranted can also be a problem. So where do these pitfalls come from? So the center line of this slide, or centerpiece, I should say, is an incorrect POCUS conclusion. And that obviously can lead to bad management decision for the patient and potentially bad outcomes. So where does this come from? Well, it can come from the actual use of ultrasound that has its limitations and has many, many artifacts, some of which are useful, like artifacts in long studies, for example, are very important and we rely on them. But artifacts in cardiac ultrasound are not that friendly, and we need to learn how to recognize them and correct for them. And then operator-related issues. Maybe the operator is not skilled enough, or maybe the patient is a more difficult patient. Maybe their body habitus is difficult. Maybe their lungs are overinflated and they are sick. For example, ARDS patient is difficult to scan. Or maybe the machine is not well optimized. Maybe the transducers are not well chosen. Maybe the settings are not optimized. And then another source of potential pitfalls comes from low intra-rater and inter-rater reliability. And this comes from really lacking of competency standards and training standards, which is, I think, a problem that everyone is confronted with. And then at the higher level of the scientific community, if there is insufficient validation of the method, then you may conduct a study very well and do it perfectly, and the image is great, and you interpret it correctly as far as you know, but it doesn't mean what you think it means, simply because it has not been either studied enough or the studies have not been conclusive or accurate enough. So all in all, there's many sources of problems and incorrect POCUS conclusions. So I will start with something simple. This is one of the examples where I did not have a POCUS study, but I used the radiology example. This is just an artifact. So it's an aortic pseudothrombus. It is very nicely shown here. So you see this linear shadow here in the aorta that can potentially look like an aortic thrombosis. And so here you can see the image with the labels, and then the artifact is this line right here. And then in the transverse section, you see the same line here in the kind of in the middle of the aorta. So is this truly an aortic thrombosis? So it's really not. It is a common artifact. This study that I, from which I took these pictures, from Dobrochi in 2013, they looked at 150 children with a mean of 8 years old. And interestingly, 26% of those had this artifact in the aorta. And importantly, one of the ways to figure out it's an artifact is that it has no contact with the aortic wall. And of course, equally important, or more importantly, why would a otherwise healthy child or a child that has a different presenting problem, why would they have a thrombus in the aorta? So if it doesn't make sense, it usually is not true. So how do you solve it? Simply by altering the ultrasound beam in relationship to the long axis of the aorta, and you can make the artifact come in and out. Of course, true aortic thrombosis does exist. It is very rare, and it's usually found in newborns. And you see an example here where the thrombus is not just a line, but it's a much more kind of globular appearing genicity, and it is in contact with the wall, which is one of the telltale signs that this is truly an aortic thrombus. So moving on. This is a typical example of a POCUS application. Most of the studies that I'm going to show from now on are mine. I think not all, but most of them. And so here's a newborn in the cardiac ICU that doesn't look so well. Look like maybe it's a little bit shocky. So I'm going to do a quick LV function check. You're right, it should be easy. I know how to do this. And so I do an apical 4. This is what I get. And I put 4 in quotes because it's really not a 4. I only can get LA and LV. So I see here a dyskinetic septum. Function doesn't look so good, but I'm not really sure. I can't really get a really good appreciation of how decreased the function really is. Okay, so I tried the plaques, the peristernal long axis view, and so really, I put here the best I can call this is a fuzzogram, because while I do see the mitral valve and the LA, not really much there, so I really cannot tell what's going on. And so, okay, I try a different view, and here in the subcostal short axis, I see the LV here, and I'm thinking, oh, maybe it's not so bad. Maybe it's not so bad. It's squeezed reasonable. Of course, the caveat here is that I'm way too distal, so I'm catching mostly the apex. And so the apex is always going to look better than the mid cavity. And so the function is really not good, but it can look like it's not so bad. So, okay, I'm a little bit stuck. Is it bad? How bad is it really? What do I do? Advance my slides. Oh, there it is. I'm confused. And so tiebreaker is a VTI. And so velocity time integral, I find it very helpful. And so you really, what you do to get that, you put your pulse wave Doppler in the LVOT, just proximal to the aortic valve. And so you get, you trace the Doppler pulse here, and so you get the velocity time integral. And there's normative values for this, and 6 is very low. So this patient truly had decreased function, and plus had other reasons as well to have low cardiac output, not just decreased function. So this is a way to kind of maneuver around the pitfall of not really being able to see the endocardium really well to really appreciate the movement of the LV or RV for that matter, ventricle. And so VTI variability, that's the next step. So, okay, I decided the function is not so good. The cardiac output is definitely not good. So does this look like it's going to respond to fluid or not? Because we know VTI variability has been shown to have a little bit better predictive value for fluid responsiveness. Both in kids and in adults, with a cutoff around 15, 18, 12%, depending on where you read. And so here I trace the maximum VTI, and I trace the minimum VTI, I get a 3.4%. So really that's not much. But then I look again and I think, oh, maybe I traced this one a little bit too generously. So I do it again, and I trace it slightly differently, and I get 13%. Okay, so is it or is it not? So the answer is you can't tell sometimes, especially when the VTI is so low, becomes very subjective. And so it really, I would say this is an example why in theory, VTI variability can be very useful. In reality, sometimes it really doesn't help. And in this particular patient, I did not give volume because the CVP happened to be quite high, and there was severe TR, and so function wasn't good. So I decided to just move on with inotropy and other measures. Okay, moving on to a different type of pitfall, pericardial tamponade on ECMO. So there has been a talk already on pericardial tamponade, so I'm not going to go through what constitutes tamponade and how to figure it out, except to say that in ECMO, things can look quite different. So this one is an example of a 10-year-old girl with a severe cardiogenic shock due to valvular regurgitation, so a little bit different than the most commonly seen types of cardiogenic shock in the cardiac ICU. So this patient was on ECMO and also had an impella. And so she accumulated this pericardial effusion. And so there was discussion whether or not this pericardial effusion is really causing a problem or is it not. And so I did this study. So as you can see here, there's a big effusion from the subcostal. And you see this RV is very small, like slit-like cavity, and the fluid is pretty large. From peristernal long axis view, you see again a large amount of volume. Maybe I should pause this a little bit so I can show better. You see a large amount of volume here, both anterior and posteriorly. You see the impella in place. And interestingly, you don't see the RV almost at all. You should see RV here, and you don't. And so it is such a slit-like cavity. And so doing M mode through the peristernal long axis view, well, we see here that, so this is effusion, and this is the RV here. So RV anterior wall, it's really, really slit. And so, of course, it will not collapse in diastole because it's collapsed at all times. And so the absence of RV diastolic collapse when the RV is already so pancaked, it really is not really helpful. And so the question was, is this RV so collapsed because it's being simply drained by the ECMO, so it's decompressed, or is this truly a problem? Again, here in peristernal short axis view, you see a large effusion, and again, the same thing with M mode, the RV is essentially gone. And then from the apical four-chamber view, the same slit-like RV, a little bit better opening here, but it's still pretty compressed, a large fluid collection. You see the ECMO cannula coming up here, and then the impella here. And so there was a lot of back and forth discussion about what to do about this case, but ultimately it became evident that it is not the ECMO that's draining, that's decompressing the RV to such a degree, but in fact, it is the fluid that's causing external compression, and the patient truly had tamponade physiology and it was drained. And so after that, post-drainage, what do we see here? It's the same amount of ECMO flow. And look, the RV is nicely opening now. And you see the ECMO cannula, you see the impella. And then even though there's still a little bit of an effusion left, it is much less. And also in parasternal long axis view, you can see the RV opening and closing nicely or contracting nicely. It has a cavity, and you can also see the impella. So the caution with this case is, yes, while the ECMO is decompressing the RV, always be careful that you have to be careful not to miss tamponade on ECMO, which will not have pretty much any of the classical signs that tamponade has. All right, so moving on to a different topic. If there's questions, I can also stop and answer them. Eric, do you think, or should I just keep going?
Oh, however you'd like to do it. It's totally up to you for the flow of the talk from your standpoint.
Okay, well, I can answer any questions. If not, so people just feel free to stop me or raise their hand, and I can answer any questions if there are. Okay, so moving on to a different topic, consolidation, lung consolidation using linear versus cardiac probe. And so how easy is to see this? And so here using the linear probe, we see pretty nice detail of consolidation with air bronchograms that don't move at all. However, the disadvantage of this is that the sector is very narrow using a linear probe. In contrast, by using a cardiac probe, you have a much bigger sector, so you can get a lot more detail and spatial orientation, but maybe you don't get quite the same clarity of a linear probe. So I like to use both, and I'm going to show examples because they both can be very helpful in figuring out pathology. So here, let's see. Does this look like there is collapse on this image clip of the lung? So at first impression, if you scan the lung in the L3, so at the axilla and a little bit lower, it looks like there is no collapse. So one could just conclude based on this, there's a bunch of B lines, lots of them, they're coming all the way down. You can see the ants marching here. So there is sliding, and so you could easily conclude this is just pulmonary edema, at least in this sector. However, if you move your probe more posteriorly, you can easily see that, in fact, there is quite a bit of collapse. And so one could easily miss this finding if one were not to scan a little bit more posteriorly as well and assess the lungs a little bit more than just in one spot. False positive consolidation. So this is, it was reported, I think, I don't know if the first time or not, but I found this citation from Academy of Emergency Medicine 2016, where they report that one could easily mistake the stomach for a consolidation. So I have a few clips here of that. So this is again done with a linear probe. So while the images are clear, the sector is very narrow. And so is this consolidation or is this something else? I mean, it kind of looks like air bronchograms, and you kind of see the lung coming in here. So at first impression, it looks like, yeah, this is consolidation. But in fact, when you move your probe a little bit more posteriorly towards the bed, you see that in fact the lung comes in here. So yes, it has perhaps some consolidation, but those that we're seeing here are not the air bronchograms belonging in this lung. In fact, this is the stomach. And you can tell because you can see the diaphragm coming here with the spleen behind it, and this is the stomach here. So this scan was done too anteriorly. That's confusing stomach bubbles with consolidation. In the same series of consolidation versus spleen this time. This is a baby on oscillator, also post-cardiac surgery. So we can see here that there is consolidation. There's all these trapped air bronchogram here. And then there's this tongue coming here that with a fluid around it that looks like maybe there's a pleural collection, a fluid collection at the base. And then this is just a piece of consolidated lung kind of floating into it. So that was initially the impression that that's what we're looking at. But is this really true? And so when you look a little bit more carefully here, you see this, and this is in fact part of the stomach. And so how to figure this out. So this is a little bit better imaging of the same. So you see this thing floating in here, this organ, and then a little bit anterior to it, this is actually stomach. And so this is fluid in the abdomen and not pleural effusion. And so how to figure this out? Scan back and forth, anterior, posteriorly. And by doing that, it becomes more apparent that this is spleen, this is stomach right here, and this in fact is ascites and not pleural effusion. I see something in the chat. I find using abdominal preset to be better for evaluating air bronchograms. I like that. I don't know what other people think, but I actually like abdominal presets to evaluate effusions quite a bit better.
Yeah, sorry, Gabby, I think it's, you bring up a great point. Like vascular access presets often cause some angular artifact that has overlapping shadows. So I agree with both of you, like, using imaging that is more designed for diagnostics tends to not use the overlapping beam patterns that are used in vascular access to make your needles shine. And rather, if you use lung or body or musculoskeletal, you'll just be using like the more vertical reflections. So that then you only have like artifact that goes straight back. So just make sure we're all on the same page. Like, each little crystal in the probe emits like a little sector. And then on vascular access, the diagonal beams intersect, and then that helps you see the needle better. But if you set it to a diagnostic mode, it only uses the vertical beams. And so I agree with y'all. The thing that I would question about using abdominal preset is that abdominal presets tend to take each frame and average them on top of each other. So as things move around in the thoracic space, everything gets really smudgy. Whereas if you use a diagnostic mode that doesn't average the frames as much, like lung, like a setting that is designed for a faster frame rate so that you can capture movement better, like a lung preset tends to shorten that interval of making frames average on top of each other. So you can see bronchograms kind of stand out more in real time rather than end up blurry if the lung's moving around a bit. Sorry,
Okay.
that's all. Thanks.
No problem. All right. Okay, I'm going to try to advance my slides again.
While you're doing that, I mean, Gabby, I do like your suggestion for like using both your linear and your phased array, needing to trade between, a sector view and versus a linear view to try to see, the trade-off between like a wide view or better resolution. And sometimes you can get a compromise on some machines. Like it's vendor dependent, but you can get trapezoid mode on a lot of systems like Philips machines, or I'm sorry, I should be more not vendor specific here. There is quite a few vendors, not just Philips, GE, Mindray, that do a trapezoid view where you can turn a linear into a sector and it looks at, instead of looking at the straight up and down bar of a linear, it'll turn it into a trapezoidal sector. So you get the wider field of view and you get the resolution of a linear probe.
Oh, interesting. I've never heard of that before.
Yeah, you would see it on a radiology machine like a G Logic series or Voluson series or the Philips Epics and all of the IEs and IUs that they have, and the M series of the Mind Rays, they all have those abilities.
Okay. All right. Well, our machines are Sonosite, so that's probably why I haven't. So this is the example coming back to making sure that we see the correct thing. This is an example of scanning from anterior to posterior, where we can figure out, and I labeled it on the right-hand side, you can figure out where's the stomach, and then as you scan more posteriorly, then you see the spleen and the kidney is in green, and the stomach is in red. And that way you can kind of figure out a bit better whether you're in fact looking at the base of the lung or the pleural space versus the abdomen. In the same vein here, again, it's kind of difficult to know on first glance, is it pleural effusion, is it ascites, or is it both? And so in fact, in this case, it's probably both. So you can see the lung here coming in and out, moving back and forth, I want to say, with some collapse, and there's probably also some fluid here at the base. But also, more importantly, you see the diaphragm, which I put here in red for ease of observation, and then most of the fluid that is seen in this clip is in fact below the diaphragm. So this is actually ascites and not pleural effusion. Okay, let me look at this. Okay, got it. All right, air and liver, which is bad. We think this is bad. And so I was actually quite surprised to find this when I was scanning a baby in the ICU, and I don't know why my clips are acting up. So this is an example of a scan I've done in one of our infants in the ICU. And so you can see here in green the bubbles of air. They're sort of linear white, very echogenic bubbles. This is air. So obviously I'm thinking, is this neck? Am I missing something? Let me do this because I think it's just going too fast. And so I'm thinking, am I missing something? Is this neck? How concerned should I be? And so I want to see where is this air coming from. And so I look to see whether is it coming from the portal veins as well, since in order to have neck really, the air has to come from there. So I try to see, is it from the portal veins? I identify the portal veins here. And then I put color just to be sure, and it has the typical Doppler of the portal. So I don't see any air in the portal, but I do see these white specks on the liver, so there's definitely air in there. And then the nurse actually gives the patient a flush, and then there's the mystery solved. In fact, there's air coming from here. So unfortunately, this happens more than I realized, and I think this is a twofold issue. One is that in spite of the filters that we have, and I work in the cardiac ICU and we have filters on everything. So in spite of that, somehow there's still bubbles that go through. And the other thing is our machines are so sensitive now that I think they pick up the tiniest bubbles that may not really have any consequence. And so this is not that uncommon to see. And every time I see this, I ask the nursing staff to please look at your lines, see if you're missing any filters, see if we entrap any bubbles, because most of these, or many of these patients have right to left shunts. And so it is dangerous for them to allow bubbles to get into their circulation. But in this situation, actually, apart from the risk of air embolism, which I suppose is pretty small because the bubbles are small, but still it exists. Otherwise, this has no significance. This is a false positive finding. But what happens when it's not? I'm sorry, this is the same case. So you see here the bubbles are back and forth in one of the suprahepatic veins and nowhere else. There's no air in the portal circulation. So this is when it's bad. And actually, this is a radiology study. It's not a POCUS study. So you see here the air is trapped in the liver, portal venous gas, and this is the radiologist quotation here. And then you also see a thick walled bowel as well. So this patient truly had a bad case of NEC. And then here the clip does show air. that is trapped in the liver. And then radiologist also looks at the portal veins to see if there's air coming through. There's air trapped here at the top. And then as the clip moves forward, you can actually see bubbles coming through at the bottom here. And so that is a case of true NEC with true air coming in the portal venous circulation. And importantly, there's not just air. This patient was also very sick, had complex free fluid, had abdominal distension, so had other findings as well to suggest this is true NEC. So I just wanted to bring that up because I think air in the liver is very scary and should be scary, but it's important to realize that there also can be a much more benign reason for it. Okay, and then so moving on to probably one application of POCUS that collects all the pitfalls rolled into one. You probably can tell I'm not fond of this IVC and fluid status specific application, but I find it very interesting to look at because there's so many things and so many ways that POCUS can lead to the incorrect conclusion. So as we all know, there's now a new concept, it's not that new, I guess, that talks about fluid responsiveness versus tolerance. As opposed to just trying to give the patient fluid. So IVC diameter changes. So either the IVC static diameter or dynamic changes with breathing. Is that correlated to the CVP? There's a lot of things that go into that. The level of mechanical ventilation, is the patient ventilated or not? Where are you measuring? What kind of volumes are you using? What is the abdominal pressure? What is the right heart doing? In fact, is fraught with a lot of problems. And as with any POCUS finding or component, it has to be integrated with the rest of the exam and also with the clinical findings. And so this is a study from adults that interestingly looked at the IVC collapsibility and prediction of fluid responsiveness. And so interestingly, where exactly they measured it had a lot to do with how predictive this was. And also not only where they measured it, but what did they tell the patient to do? So these were patients that were not mechanically ventilated and they were not that sick. And so interestingly, when there was no instruction there, just looking at the patient breathing, none of these area under the curves were that great. I guess the number 4, so measuring here under the suprahepatics, was the best. But when they did instruct the patient to breathe in a particular manner, the sniff test or some variation thereof, the area under the curve improved significantly. So something as trivial and simple as where you measure it and how the patient breathe can actually make a huge difference. What about in kids? What about the translation of the IVC in and out of the beam? To me, that is a big deal, and I found it commonly in the studies that I review and myself doing them as well. So because our patients are small in general, with breathing, the IVC can translate back and forth, so either in the transverse plane or in the longitudinal plane, such that you measure different things. And so this is why, for example, switching from M mode to B mode can correct some of the craniocaudal translation with breathing, whereas B mode or M mode are equally fraught with error when the IVC moves in the lateral plane with breathing. And so you get the conclusion that the diameter changes much more than it actually does. So as an example, and this is actually an echo clip, when you look to the left, it does look like the IVC collapses quite a bit with breathing. Of course, any observer that is paying a little bit of attention will say, well, wait a second, this suprahepatic here is very plump, and so that cannot be it. And that is true. But let's just say you didn't have this helper here. You could just look at this IVC and think, it collapses pretty good. But then when you actually take the true maximum diameter of the IVC in long axis and analyze that, you realize that no, in fact, there is really no diameter change or minimal diameter change with breathing. And so this would be a case where you would say there is not much variation or no variation, and the IVC diameter is very big. And as a bonus, you can also notice the difference between the diameter of the IVC, which is very plump, and the diameter of the SVC, which is definitely not, which is much smaller. And also as another bonus, there's a little thrombus there that's floating. Bonus for us, not so much for the patient, I guess. This is another example where the IVC actually, this is the clip that I took, where the IVC moves out of view completely. And so if you're not really paying attention, you could say, well, there is significant variation. This IVC is completely collapsing, but in fact, it is not. It is simply with breathing moving out of the ultrasound beam. And so you could get a false impression of collapsibility. Okay, and moving on to validity, how valid is this? And I'm not going to get into a whole lot of detail. I know Eric has talked about this subject in his talk, and others have touched on it too. Just to say, just a very few pickings from the literature, there's really not good evidence to suggest that fluid responsiveness can be predicted by diameter changes with breathing. So for example, the study in 2015 showed no ability to correctly predict fluid responsiveness of changes of the IVC diameter. And this was done very well. Patients were mechanically ventilated, paralyzed on very, very well-controlled settings, and they did not find anything useful. The validity of the IVC, I'm sorry, I left that slide. I should have taken it out. So this is the study here that I was going to mention. So 51 children in the PICU, where they looked at whether IVC variability predicted CVP. And again, it really didn't. The collapsibility index, and they used 50%, so a pretty high number, had 14% sensitivity, 83% specificity, so relatively poor predictive value, both positive and negative, of collapsibility index to predict a CVP less than 8. And finally, in adult studies, this is a meta-analysis looking at the accuracy of ultrasound measurements of IVC to determine fluid responsiveness. And I won't go through all the details. They looked at a lot of studies. They found a lot of heterogeneity, which is not surprising given the many problems that can happen and the many variables that could be different from study to study, and even from patient to patient or from operator to operator. But in conclusion, ultrasound evaluation of the diameter of the IVC does not seem to be a reliable method to predict fluid responsiveness. That's not to say, similar to what Eric said in his talk, that's not to say I'm saying pitch it out of the POCUS exam. I think sometimes it is a little bit helpful to me when I see a really, really plump IVC with no changes in diameter whatsoever. That tells me something. It usually tells me that the CVP is on the high side. I don't know how high. I just want to say high. And when it's really, really skinny and collapses really easily, I'm going to say probably this patient will be fluid tolerant, not responsive, but tolerant. So if fluid was an option, patient would probably tolerate it. And then to make matters worse, we say, okay, well, IVC collapsibility or distensibility is not that helpful. So what do we have? Do we have VTI variability with breathing? So that has been shown to be better. But look what can happen in a small child when you do this. You do it, and then it looks like there's extreme variability. But really what happens is, and I'm going to slow this down, what happens is the LVOT moves in and out of the plane such that the pulse wave Doppler moves in and out of the LVOT. And so you get these and of course this is measured a little bit too generously, but still I think the message is still clear. So when the pulse wave is well into the LVOT, you have this nice filled in Doppler, whereas when it's out, you get this skinny, mostly empty envelope. So if you compare these two, of course, the variability is extreme, but in fact, this patient did not, this was not a true finding. This was a false positive due to the LVOT coming in and out of the ultrasound plane, which happens in infants that are breathing fast and somewhat heavy. And just to contrast this is an example of a true VTI variability, where you can see some degree of variability. I'm going to guess around 15% here, but the quality of the Doppler pulses, envelopes, does not change from beat to beat. So this is not a false positive. It is a true positive of VTI variability. So with that, I'm going to end by saying that we all start here, where we're pretty damn sure that we know a lot and we're feeling great about it. I've long passed that phase. I've been hovering in the insecure canyon for a while, and now I'm mostly here in the grown-up mountain. And while I'm passionate for POCUS, I do encourage everyone to know that being up here is not in the patient's best interest, and I encourage everyone to move towards the grown-up mountain and recognize both the wonderful attributes of POCUS, but also its limitations and pitfalls, and understand the importance of rigorous and continued training, because ultimately, sometimes it is that easy, and sometimes we can truly make a difference.